and welcome to the Oral and Maxillofacial Surgery Unit. First things first, this unit is indeed titled Oral and Maxillofacial Surgery, but quite often the oral and the maxillofacial get squeezed into a single word, and so you're going to hear the term oromaxillofacial a lot. Oromaxillofacial surgery and surgeons focus on reconstruction and repair of the facial bones. That means we're going to learn the different bones of the face in this unit, as well as focus on the structures of the oral cavity, including the teeth. Oromaxillofacial procedures are performed by a myriad of surgeons, including oromaxillofacial surgeons, plastic surgeons, ENT surgeons, as well as oral surgeons. The face is divided into three sections. They are the upper face, the midface, and the lower face. Each section of the face is comprised of its respective facial bones. That is the challenging part. So, the upper face is comprised of the frontal bone and all of the bones in the bony orbit except the ethmoid. The midface is comprised of the ethmoid bone, the nasal bone, the zygoma, and the maxillary bone. You'll want to make sure that you know that the ethmoid belongs in both the bony orbit in ophthalmics and the midface in oral maxillofacial. Do you remember where the nasal bone is from ENT? Is it down by the nares or is it up by the eyes? And the zygoma bones are the ones that are accentuated by makeup artists, otherwise known as the cheekbones. The zygoma bones have an alternate name. Can you find out what it is? And finally, the maxilla, which is the upper jawbone. The function of the midface is to protect the orbits and cranium. It also resists vertical forces of mastication. The lower face is comprised of the mandible, or lower jawbone. The mandible is the only movable bone of the face. The mandibular condyles insert into the glenoid fossa of the temporal bones to form the temporomandibular joints, otherwise known as TMJ. The trigeminal nerve is the fifth cranial nerve, and it also happens to be the largest cranial nerve. There is a right and left trigeminal nerve, innervating the right and left sides of the face respectively. It is responsible for both motor function of certain structures like biting and chewing, as well as sensory receptors of the face, like eye pain or tooth pain, temperature, and so on. It is not uncommon for patients with oromaxillofacial trauma to have additional complications like numbness in other areas of their face, because the trigeminal nerve covers it all. Before you come to class on Thursday, make sure you've read your chapter in fuller and be able to answer these questions. What are the primary reasons that we do surgery of the face? What are the most common types of injury? What is the primary means of repairing facial fractures? And who is responsible for keeping track of all of them? Understand that oral maxillofacial surgery can involve the skin, the muscles, the nerves, blood vessels, and these procedures have the potential to be very complex and involve a variety of surgeons. Although we are rarely involved in the assessment of patients and their surgical procedure selection, it is still important to understand how and why things are done the way they are. For example, when someone comes in with a potential facial fracture, you can imagine their face will be inflamed. It's obvious, then, that a physical assessment is not performed, because it would really hurt. Furthermore, you know a lot about diagnostic technology now. Since a patient can't have their injuries assessed physically, how do you anticipate them to be assessed? If you said imaging studies, you're right. CT scans and MRIs are a maxillosurgeon's best friend when treating trauma patients. But there's something you as the ST can do to help anticipate the needs of your surgeon in the OR. What could that be? Well, I would anticipate having those imaging studies ready and waiting in my assigned OR if at all possible. Then, throughout the procedure, the surgeon can reference the diagnostic tests that have been performed. So, if the most common method for repairing facial fractures is with plates and screws, you'll recall from our ortho unit last semester there will be some integral instruments that go along with those plates and screws, right? So, you'll see guide wires, drill bits, depth gauges. What type of fracture does this describe? We'll also have power drills on our field. And what should you be thinking about when a drill is being used on your field? And remember, if a screw is implanted into the patient, even partially, it may not be re-sterilized and used again on anyone else. That screw has been bought by the patient, regardless of whether it remains in them or not. So keep track, because implants are documented and everything gets charged for. Here you see some instruments and an example of a facial fracture tray. You'll want to check out a few additional instruments in your instrument book as well. Look and read about the wire cutters, the Rubio needle holder, Joseph skin hooks, Brown AdSense, and Webster needle holders. You'll encounter these instruments regularly when doing procedures on the face. Facial fractures are prepped with betadine. ChloraPrep poses a threat to the eyes, ears, and mucous membranes, all of which are near one another on the face. The endotracheal tube is regularly included in the prep and subsequently in the sterile field. We must be very careful not to jar it during surgery, since that could affect the patient's airway. In the event of a bicoronal incision, the patient's head must be shaved. In many facilities, hair from a patient's head is treated like a personal belonging. I personally have worked in a facility that always sent the hair home with the patient to do with as they liked, but I've also worked in facilities that disposed of it. So it's always a good question to ask if it's your first time that you're exposed to it. Additionally, if the eyes are not to remain open for the procedure, the patient often receives ointment before the prep begins to keep the eye moist. It is not uncommon at all for a throat pack to be placed after the patient is under general anesthesia. It's imperative that the packing be charted, considered in the count, and removed before the jaw is wired shut. We'll talk more about wiring the jaw shut during the arch bar placement in Jigsaw. We're already at the final slide for your lecture videos for this unit. You can rejoice that there are no new medications to learn for this unit. The same medications you've already learned are utilized in oromaxillofacial surgery, such as saline, local, and epinephrine. I mentioned during the last slide that the patient's eyes may be lubricated to keep the corneas moist during surgery. This may cause the patient to have blurry vision after surgery, but that's normal. During surgery, you can anticipate using Ratex, cottonoids, and wax sponges as the procedure is appropriate. We count the radiopaque sponges just like always. Lastly, external incisions are typically coated with an antibiotic ointment, and they rarely receive any additional dressing. That is the end of the lecture videos for this unit, and when you come to class, we will address any questions that you may have, and then we will move right into our jigsaw for the day. See you then!